Is a diplomat of the American Board of Obstetrics and Gynecology and is board certified in general obstetrics, gynecology, and the subspecialty of maternal fetal medicine. He's authored over 70 peer-reviewed articles in OBGYN literature, presented over 100 scientific papers, participated in over 40 research projects, and published several articles on perinatal hospice. He is an original author of the Perinatal Hospice concept, which provides a multidisciplinary care to families with a lethal prenatal diagnosis. Dr. Calhoun serves as professor and vice chair in the Department of Obstetrics and Gynecology at West Virginia University in Charleston. He's also the National Medical Advisor for the NIFLA, or the National Institute of Family and Life Advocates. So please join me in welcoming Dr. Byron Calhoun.
Right here, my stentorian voice. I really appreciate you inviting me. This is not unfamiliar to me. I spent 6 years in Biloxi, believe it or not, with the Air Force, so I spent a lot of time visiting over here in New Orleans. My children who are over there going to the zoo and doing stuff, so it's kind of interesting to be back. I really like this time of year better than July, so I will say that. Well, I'm going to talk about perinatal hospice, and really what I want to do is sort of set the ground up, work from that, and talk a lot about why I do it and what it's a result of and what it's come about, essentially. My small hospital is a children's hospital, about 250 to 300 beds. It's a freestanding women's and children's hospital. I have 12 residents, 3 each year. I have probably 50 to 40 pieces of medical students that come through all the time as well. Well, for those of you who are very German, you like to know where you're going, you like to know about order, this is what we're going to do today. We talk about hospice concepts, I'm going to define it, how we do it. I'm going to show you some results from some papers I've written, and then I'll talk about some challenges for you as the people that are going to be hopefully taking this on in the future, because this isn't going to go away anytime soon. And basically, I just want you to understand and be familiar with, and maybe something you can develop this in your area here. I don't recall there being perinatal hospice in New Orleans. I don't think I saw it. I always like to show pictures of my family. This is my cute little granddaughter. That's Katie. And my other daughter here, I'm making my red shirt. I would never even seen that otherwise. And we're watching Beauty and the Beast at Disney World. Well, what about anomalies? And this is where it's a very interesting discussion, because if you look at how many anomalies there are in the country, it's the leading cause of death after birth or newborns, about 22 to 43%. And so it's about 6,000 to 10,000 a year, which doesn't sound like a lot, but when you think about it every year, it actually is a big number. Also, that number really is 0.05 to 0.07, because why? You have to read the words carefully. It's at birth. So the other ones are all terminated, so that's the ones that are born. So there's actually a lot more. There's actually between probably 15 or 20,000 to 40 or 50,000 per year. The traditional concepts and things I grew up with and what happened before was everybody said that we should just have a termination of pregnancy because we're going to get over with it. And since I'm a surgeon, I like to do stuff, right? I want to do something. Because that's what surgeons do. They do things. They operate. They do things. That's what surgeons do. Well, it's really a well-intentioned desire to try to avoid complications, which we're going to show are actually true, and the fear of increased maternal mortality, which also is true. That's my mother. She was 93, she's going to be 96. My mother is Maxine. Anybody know Maxine is? The cartoon character? That's my mother. Yeah, that's my mother, Maxine. You know what I'm talking about? Yeah. Very scary lady. You're 96, she's still scary. Well, what about what really happens? Well, it's always good to look at the literature, isn't it? It's always good to look at literature with other people, right? Because then you can't be said your bias is something you just decided you want to do. If you look at grief after termination, or wanted babies with anomalies, it's not as simple as it sounds. Because if you look at 2 months of this, with 23 women with case control for anomalies, 17% had major depression in 2 months, and 22% had already sought psychiatric counseling. Now, these are people that have babies that they wanted, they terminated for fetal anomalies. Okay? That's a small number, right? Well, God bless the Danes and the Germans, because they like to keep track of everything, right? That's great. And everything's in a database. And like here, Denmark's a relatively small country. They have had socialized medicine, and actually a central database since the late 60s, early 70s. Every one of your medical interventions, every one of your visits, every one of your procedures are all in a page database. So you can get to all the stuff you want, including all the outpatient visits and all the medications. Extremely important to be able to do that. Because what they did is they looked at 147 women. Now, that's starting to get to be a few more people now. So that means they're starting to think about this might really be useful. And they looked at the psychological outcomes at 4, 8, and 16 months. Because everybody says, well, if you ask them in 2 months, 2 weeks, or 3 weeks after that, their termination, they feel relieved. Listen to the words. Relieved does not mean feels good. Let me show you why. At 4 months, 46% of these women had pathological levels of post-traumatic stress, and 16 months, 21%. Does anybody know what post-traumatic stress is? What is it? Intrusive thoughts, nightmares, flashbacks, can't function. So this is not minor depression. This is not stuff that you can just get over. So anytime somebody says you're just going to get over this, that's not going to happen. You're not going to just get over it. All right, another cross-sectional study was done actually, and what they did is they looked at 253 women with terminations prior to 24 weeks. Again, evaluating 2 to 7 years post-termination pregnancy. They still found 3% almost were pathologically free, and up to 17% still have nightmares, still have intrusive thoughts, still can't function. So the next time somebody says, well, just have it, you still have like your termination, you can just get it over with, right? Because I hear that all the time. I'm not making this stuff up. I hear it every day. You don't get over it. Okay? It just doesn't work. Unless at least a certain number of people just don't know. Well, what about miscarriages and live births, spontaneous losses? Well, they did a nice study that was done in Denmark again, and they looked at the first 6 months that they had increased depression, anxiety, and somatization in the loss group versus people who gave birth. What's very interesting, you give a spontaneous miscarriage or a loss, by about a year, there's no difference. So what's the difference between a spontaneous miscarriage and a terminating an abortion? Oh, I just like to show this in such a cute picture. This is my daughter, Mercy, my princess. This is her. We also know, since we're in the age of autonomy, we all get the autonomy lecture, the latest discussion, the non-malfeasance lecture, the 4-box, your ears model lecture, right? Yeah. The 4-box model, yeah. So autonomy trumps everything, right? Really, it trumps everything. So if somebody wants it, you're supposed to give it to you. Is that correct? No, I'm being serious now. Really, seriously, that's where we're headed with this stuff. You should do it because you can and because somebody asked you. Well, at least 20% of your patients are going to ask you they don't want to terminate. And in fact, I'm sure some very interesting data that it's much higher than that if you actually ask people and you give them an alternative. Mortality is higher if you do deliveries versus doing abortions. No. Actually, if you look at the data from maternal mortality, which is 10 per 100,000, which is also not accurate, we'll talk about that if anybody else wants to talk about that later, versus abortion at 20 weeks is exactly the same. So they don't die of one, you're going to get pregnant and have a baby. So that's another big fat lie. Cross that one. No increased death rate. And this is from the literature. If anybody wants the slide, you can read it yourself. I'm not misinterpreting this stuff. I'm glad you can get the slides. You can pull the paper and read it yourself. I'm good with that. Well, that's my lovely first wife, Catherine. And we're going to have a little soiree. That's just graduation. Okay. Well, what are the hospice concepts? I know this is your lovely first wife. You have another one. No, I only have one, and she is my lovely first wife. And she always has family say that, so I don't say it. Word of warning, guys, don't do that. It's not funny to the ladies. It's funny to you. It's not funny. You think after 30 plus years of marriage, I'd learn by that? It's because I'm a guy. So Cecily Sanders said, what do people really fear when they're dying or they have a fatal diagnosis? What's the biggest thing they fear? You always hear it's pain, right? That's not true. What is it? It's what? No. That's close, but no. They don't want to be abandoned. And what Cecily Saunders found was happening in England was that people that were dying were being put in rooms and just left to die in the room. You're not dead yet, but they're treating you like you're dead. People that are dying or having a fatal diagnosis don't want to be treated like they're dead. So that's their biggest fear. And she actually started as a social worker, went to nursing school, and then became a physician, and actually was then made a dame of the British Empire because when she said, we need to stop doing this. And this was back in the late 50s, early 60s. And that's when she developed that. Well, it's a very useful framework for looking at perinatal hospice, and we'll explain why, okay? People started doing this for childhood cancer, right? Neonatal hospice and perinatal or pediatric palliative care and treating children, people or with terminal diagnosis. Again, the idea is to bring people close and draw them in. It's not to abandon them, right? It's not very high tech, it's very high touch. So that worked very well, but the problem you have on the OB side where I live is, what's the problem? They're not born yet. they're still in mom's uterus, right? So there's no pediatric patient, there's no adult patient. Simply there's a mom and a baby, right? There's two patients, and there's a family involved with this thing. So it's not just the same thing. So we needed a little different model. Oh, isn't she cute? That's my second favorite. That's Penelope. She's a cute little ginger, isn't she? She really is cute, I have to say. She just turned 1 and she's just... Well, what is perinatal hospice? I call it the prenatal diagnosis of a terminally ill fetus. It's part of in utero care leading to perinatal hospice. It's part of the continuum of end-of-life care. That's kind of a mouthful. It's hospice care for the babies before they're born, for their moms and their dads as well. So, what you're allowed to do then is provide the same level of care, the same level of palliative care that you would apply to other people who aren't born yet. And some people find that to be radical. I don't find that to be radical at all, so it because I always have 2 patients. It's just a natural flow out for me. But nobody was doing this. Nobody was putting this together and providing this sort of idea. Well, for us, it's fairly comprehensive. I mean, we have, whenever I do this, you have to have social workers, you have to have chaplains, I've had priests, I've had all sorts of rabbis, I've had people that are Orthodox Jewish rabbis, I've had mullahs from Islam, and all sorts of people who put on the spiritual side. The psychosocial needs have social workers, I use the psychologists, the psychiatrists if necessary, and of course you have to have a bit of obstetrical team, because you want to take care of these people very well. Labor and delivery nurses, postpartum nurses, medical students, residents. Nothing's worse than going to say, well, Mrs. Smith, how's your baby? You're the one that died from anencephaly? Well, that's not a good thing, right? And you get caught before, right? Somebody told you she had a baby die. So you can walk in there. Not a good thing. Well, what we do is we do this with terminally ill babies, and of course that's changing rapidly. 10 years ago, you would have said that certain babies with hypoplastic left hearts were fatal. Now we're catheterizing those babies under protocols, and they're actually putting the catheter in and opening up the mitral valve that's stenotic and growing left ventricle, right? So repairing the uteroneural tube defects, and in utero surgeries on cystic adenomas like lung malformations, doing all sorts of wild and crazy stuff that 10 or 15 years ago was not even thought possible. So what's fatal actually changes rapidly. And the focus that we have really is on the patient. Once you make the diagnosis, which is sort of my job as a maternal medicine, then really what you're doing is you're providing a lot of high-touch care. And I always tell everybody at this point of the lectures that this is something that requires a specific set of skills. One, you want to be able to listen. Right? You have to listen. And 2, you have to really want to do this. So if you don't do it. Okay? Don't do it. Because you won't be good at it. And you'll make yourself and everybody else miserable and crazy. So it's not a great thing, just don't do it. This is my other daughter. This is that's my wife. And my other daughter, it's Floppy Faye. She is mitochondrial disorder of some sort. I'm not sure exactly what it is. Some sort of probably minor deletion of some kind. She requires full care, and she is 23. But the handicap with her would be your head, not hers. She worked because she'd think maybe she'd get that. She'd ring with a wheelchair. She'd run over the Well, I've had all these things in the past. I still have residents, I still have sonographers, I still have nursing services and chaplains, I still have social workers and social services. So I don't have fellows anymore, which is fine. Actually, gives the residents and students a lot more time. I think better opportunities to train these fellows. I get the way up there. I'll be honest with you. Steal stuff from you guys. What I do is, since I'm a military guy, I kind of like wire diagrams to help me kind of keep it flow, and I like to write stuff down because that helps me focus on what I'm trying to do. Basically, you have a lethal anomaly, and I do hospice care, and you do non-aggressive therapy, or you do fluids or ICU. Sometimes kids will actually go on ventilators, some want to have no support, basically just comfort